Well, good evening, all attending delegates from India, and good morning, good afternoon for people who are listening to us from outside India. Well, college believe you are all keeping absolutely fine. College is happy and contented that we are able to reach the 200th mark of doing continuous webinar. We started sometime during the cold middle period of mid 2020. And we never thought we would be able to push this far. And with your help, we were able to carry on with our quality webinars as a collaborative teaching and expertise sharing for all these long. And now we believe we may be able to handle this for some more period of time. I am thankful to all for allowing us and guiding us to carry on with the program. Today, we are arranging a talk show. The talk show is guided and moderated by Dr. Sunanda Gupta on a subject which is very close to health, on obstetric emergencies and anesthesia. Well, Sunanda, you know very well, is a founder president of the Obstetric Anesthesia Society. And she is still working very hard to keep up the society and bring it to some international levels. And we hope we may be able to have more participants today, since we have the best of the faculties or the masters in obstetric anesthesia from India are participating. Sunil, Anju, Kajal, and Ravindra are joining us along with Sunanda. And I really wish to have this particular program going on very well. This is our 200th webinar. And very soon, in another 2 months' time, say in July middle, we'll be having the 4th year completion, and we'll be getting on to the 5th year of the webinars. And don't worry, we were able to do it this war, and I'm sure we may be able to carry it on for some more period. And another good news I have to break, because nobody else in the world were able to do a continuous webinar on a particular day at a particular time for 199 times, and here is 200 times. Now I request all my colleagues in the core group of ICA to felicitate the program and say some words about the program and how we should go further. I request President Indian College of Anesthesiologists, Dr. Jayashree, to address you all.
Good evening, dear friends and delegates who are attending the webinar. I bring greetings from the Indian College of Anesthesiologists. We are very proud to announce our 200th webinar this evening, which is being conducted consecutively every Wednesday since the last 4 years. This really brings us pride, because what we have seen is the feedback that we get after the viewers who have seen it on the YouTube, and those of you who are listening to the webinars live. The views, the feedbacks are excellent. The viewers have increased in the last 4 years, and this makes us, of course, very, very energetic to do better every time. We've always had a mix of webinars, a mix of subjects in which are, of course, the subjects which are of interest to the postgraduates. We started with simple subjects, And then we went on to the PG assemblies, PG interactions, PG's talks, in which they were also interacting in this webinar. And that has been really very, very fruitful. Gradually, of course, we will be encouraging our students to participate more, and we shall be discussing how to take this forward. Just for you all to know, our ICA Con, that is the yearly conference of the Indian College of Anesthesiologists, the 5th International and 15th National, is going to be held in Lucknow this year. And you will get all the details as you saw on the website. Please go ahead and register for it. And our new yearbook shall also be released during the conference. We have we have so many luminaries on the webinar today. They are all masters in their field, and we are very keen to hear their talks on obstetric emergencies. I welcome them all, and they're all, of course, members of the Indian College. But as a protocol, I would like to welcome and thank them. Thank you very much. And may we now have Dr. Baljit say a few words for the Indian College.
And good evening to all the participants in India and abroad. Greetings to you, everyone. It's a landmark day. You know, the 4th year running and 200th webinar consecutively going on without even a single break. It's no mean achievement. And this has been possible only because of the tremendous response from the participants. That's been a motivation to all of us. I remember sometime back, there was some talk about changing the frequency from once a week to maybe every fortnight. But Dr. Radhakrishnan was very steadfast, very, very, very firm that we must continue with every week program. And I think I would like to say thanks to him personally for insisting that it must be continued every weekly. This is a program which every anesthesiologist loves to attend, particularly the youngsters. They are very fond of the YouTube, the recordings that they tap on for their own gains. And I think as a part of the program and as part of Indian College of Anesthesiologists, I'm tremendously proud of everyone who is engaged in this program. Special thanks to Dr. Sanish. Well, it's no mean achievement to do it every week, the computers, the graphics, to contact the speakers, arrange everything. Hats off to you, Dr. Sanish. Obliged to you for all the effort that you've been making. At the risk of repeating everything which Radhakrishnan said and Dr. Jashri Sood have said, I think I would stop short of this and would love to hear the great speakers. The selection of speakers, Dr. Radhakrishnan and Dr. Sanish, is tremendous. Dr. Sunanda Gupta, Dr. Ravindra, Dr. Sunil Pandya, all our authorities, Dr. Kajal Jain, Dr. Akilandeswari, and of course, Dr. Anju Grewal. Looking forward to hear from the words of wisdom and the tremendous experience that each one of you have. Thank you so much for joining the program and look forward to hearing to you. Thank you.
I request Dr. Murali Kanchi to have a word to us.
Good evening and thank you for the invitation. I really enjoy the ICA webinars. I'm delighted to welcome you to the 200th webinar. And the ICA webinar is almost a part of the Wednesday daily routine now. Every Wednesday, 7 to 9 p.m., we are hooked on to the webinar to listen to the greats in this field of anesthesiology. Thanks to ICA leadership, starting from Radhakrishnan, Jayashri Sood, Baljit, Sanish, Dr. Belani, and others. Thank you so much, and I'm looking forward to a wonderful session. Thank you so much.
Thank you. I believe Dr. Kumar Belani is now available on the net. Will you address Dr. Kumar? Well, I believe Dr. Kumar is not able to show up. I request Dr. Sanish, who is the real man behind running the program without fail. And I request Sanish to have a word on this auspicious occasion.
Thank you very much, sir. Thanks everybody for the wonderful support and encouragement for this program. So I look forward to your continued support and patronage. And from the audience, we would still like to hear your feedback and suggestions for improvement. Thanks again. We'll proceed with our programs. Thank you, sir.
Thanks, everybody. And now I request Dr. Sunanda Gupta to start the program. Sunanda is going to moderate as well as speak on the subjects and give comments as well as face the question answers in the most profitable and economical way for all of us. Dear Dr. Sunanda, please.
Thank you, Dr. Radhakrishnan. And good evening, delegates, colleagues, and the executive team of ICA. Thank you very much for providing us this opportunity to host the 200th webinar series of ICA. Today is International Family Day, and so what an opportunity to talk about the backbone of families, the woman who plays an integral role in the society and is crucial to the growth and development of the communities. So today we have laid out a symposium on obstetric emergencies with stalwarts of obstetric anesthesia. And today we have Dr. Kajal Jain from PGI Chandigarh, who will be talking about obstetric hemorrhage, followed by Dr. Akilandeswari from SRMC Chennai. She'll be talking about the convulsing patient. Dr. Sunil Pandya from Hyderabad will be talking about the cardiac compromised patient. Dr. Ravindra from Shimoga will talk about accidental high spinal, and Dr. Anju Grewal from AIIMS Bhatinda will wind up with maternal cardiac arrest. And then we will take questions. All the stalwarts will answer your questions, and I request you all to post your questions in the box there. So before these stalwarts start their obstetric emergencies, we'll give you a quick review of current status of maternal mortality in India, and some suggestions on how we as anesthesiologists can contribute towards bringing down this maternal mortality rates in our country. So before I start, I have no financial disclosure or conflicts of interest, and I bring to you greetings from Geetanjali Medical College and Hospital, Udaipur, where I work as Emeritus Professor. This was a latest article which was published in February in the International Journal of Obstetric Anesthesia. And here we had talked about the lower and middle income countries, the human resource deficiency, which are proving a major hurdle in restricting safe anesthesia care. So India, as you know, has one of the smallest pools of anesthesiologists, according to WFSA. There are only about 1.27 anesthesiologists for 100,000 people.
Ma'am,
And-
share your slides, ma'am.
Hello?
Share your slides, ma'am.
Oh. Is it visible?
No, ma'am.
Not visible.
Sanish, please find out the problem.
Ma'am, have you shared the screen? Dr. Gupta, have you shared the screen? Yeah, that's
Yes.
right. Now it's
coming
visible.
in.
Now it's there.
Make it full screen, please.
Okay. Is that fine?
Good to go.
Yes.
Yes. Go ahead.
So as I was saying that today is the International Family Day, and it is the best and opportune day to talk about backbone of families. So women plays an integral part, and I have no disclosures. I come from Gitanjali Medical College, and this is the latest article which was published in February 2024, where we talked about the lower and middle income countries, and human resource deficiencies are a major hurdle which restrict provision of safe obstetric anesthesia. According to WFSA, we have one of the smallest pools of anesthesiologists in the world. It is close to 1.27 every 100,000 people. And according to the Lancet Commission, we should be having a density of 20 anesthetists per 100,000 population. But perhaps in our low resource situations, even 5 physician anesthetist providers per 100,000 population could help us to achieve the sustainable development goal of a maternal mortality ratio of less than 70 per 100,000 live births by 2030. Now, if you look at our country, there's a huge disparity in the maternal mortality rates. The states which are high achievers are Kerala, Maharashtra, Telangana, Tamil Nadu, Andhra Pradesh, Jharkhand, and Gujarat, who have achieved a maternal mortality rate of less than 70. While the low achieving states like Assam, Uttar Pradesh, Madhya Pradesh, Chhattisgarh, Rajasthan, Odisha, and Bihar tend to skew our maternal mortality rates. So what exactly can we be doing there? What are the common deficiencies we face in anesthesia practice? There's none or scarce availability, lack of standard uniform clinical practice, multi-para monitors, consistent supply of safe anesthetic drugs and equipment is problematic. Availability of blood and blood products is at a premium. And since many states do not require dedicated credit hours to review their practicing license, the enthusiasm to participate in didactic and practical skill training is missing. The patient challenges that we look at are the 3 delays model, where patients do not seek care in time because of lower literacy rates or lack of awareness or social cultural factors. They reach the healthcare facilities because their reach is delayed because of poor infrastructure and poverty. And even if they reach these healthcare facilities, you find that trained healthcare personnel are not available. So where do we stand today? We still have hemorrhage as one of the leading causes of death, closely followed by sepsis, preeclampsia, and unsafe abortion. Okay, we are the low resource countries, but what about the high resource countries? Why are the numbers of maternal mortality increasing steadily in the US? They contributed to older age and comorbidities, assisted reproduction, plus multiple gestation, increase in cesarean delivery rates. And this is common to high income, middle income, and low resource countries also. But opioid use disorders and racial disparity are something which the Western countries have to deal with now. There's a spectrum of opportunities for anesthesiologists to reduce maternal mortality, and a lot of journals have come out with articles on this issue. And the Physician Anesthesiologist and Maternal Mortality by the Anesthesiology News talks about 7 important ways that you and your institution can do to save women's lives. So first and foremost, anesthesiologists should speak up, and they should communicate with the obstetricians and the heads of the institute so that they make them understand how important the anesthesiologists are. In this procedure, an early consult for high-risk pregnancy, protocols, mandatory protocols for all comorbid patients on admission, and an early consult for developing emergencies should be in place in each and every obstetric unit. Secondly, be a leader, take charge. With your background of critical care, you are the best person to take a lead in the multidisciplinary team, which consists of obstetricians, nurses, neonatologists, cardiologists, hematologists, and so on. You need to organize simulations of catastrophic events for each and every member of the multidisciplinary team to optimize the patient outcome. Third important is implementing the safety bundles or toolkits or cognitive aids, which are freely available on the net. And implementing this, I can understand, is a big challenge in some institutes. So you need to seek peer support, and this is only possible with a multidisciplinary team. So, for example, if you have to implement the modified obstetric early warning scores, that should be mandatory in each and every unit. These are based on the 6 vital signs, abnormal physiological parameters, and if the patient jumps from orange to red or green to orange, it triggers a color-coded response. And this is based on the urgency of clinical review and frequency of monitoring, and this escalates the response from the physician. So this is a simple bedside tool which can be easily implemented in all obstetric units, and diagnosis of high-risk pregnancy can be done. The other issues are levels of maternal care. You should be familiar with the level of maternal care in your institute, and all those patients who are high risk, and if your level of institute is level 1 or 2, you should ensure that she is transferred to the appropriate facility. Listen to your patient. Always remember, mothers have a sixth sense. And if a woman says something doesn't feel right before, during, or after the birth, listen to her concerns and check them out. Apart from this, what is important is that each and every institution should have its own maternal morbidity and mortality review. And this helps in tracking and benchmarking the progress to determine what you are doing right, what you can improve upon, and what you can learn from your experiences. So as the experts in critical and emergency care, physician and anesthesiologists are best equipped to seize leadership roles and help to shift maternal health management from a reactive to a proactive strategy. And this can be done when you work closely with your obstetrician. You are able to identify and involve yourself in planning care for the high-risk pregnancy. And also, you can help the maternity care team efforts to assist mothers to recognize early warning signs and seek help. A report from Embrace UK also highlights the important role of anesthesiologists to utilize human factors training to support the wider multidisciplinary team, and urge anesthesiologists to be proactive and put in the input for high-risk pregnancy. So to conclude, an efficient obstetric anesthesiology service requires not only a cohesive, well-trained manpower, essential drugs and equipment, and adequate infrastructural support, but there also has to be a coordination between the anesthesiologist and the obstetrician. Standardizing strategies that focus on checklists and protocols enhances patient safety, and regular audits assist in identifying the barriers that are related to service provision. So in the end, it is vital that anesthesiologists across the country step forward and lead the way in providing the safest and most effective care to all women who come to your institute for pregnancy, childbirth, and postpartum care. Thank you. And now we go on to the obstetric emergencies, and Dr. Kajal will be talking about obstetric hemorrhage. Dr. Kajal.
Yes, ma'am. So can I share my screen, ma'am? Now,
Yes.
is my screen visible?
Yes.
And is it now full
You-
screen? Is it full screen, ma'am?
Yes. Now
Yeah.
it's full.
So thank you very much, ma'am, and thank you very much, Indian College of Anesthesiologists and the leaders of anesthesia in ICA. And from the core of my heart, I appreciate the steadfast and the consistency that has been shown over so many years of the time, of the day and the date, and continuing education, which you are imparting to all our Indian colleagues on this webinar platform. So ma'am has rightly kick-started the topic today on obstetric emergencies, and she has highlighted how important it is for us to be aware of our own setup and how we can be the lead as an anesthesiologist all over India to prevent maternal mortality. And among these mortalities, we all know the most important is the one which ma'am also highlighted, that is obstetric hemorrhage. And especially when it becomes massive and you see the blood is pooling on the floor. So that is why I have written blood is pooling on the floor, also massive postpartum hemorrhage. And we all know that world over, the global deaths due to severe bleeding after childbirth is a major cause of maternal mortality. And it accounts for about approximately every year, it accounts for more than 14 million women. They die because of this reason. And in India, of course, is in the grip of the same. In India, the reported deaths are approximately 20% of our entire mortality. And it is both for vaginal and cesarean, more for cesarean and less for vaginal. So there is a role for anesthesiologists to be very tuned to this fact and understand why these women die because of obstetric hemorrhage. And for this, I wish to highlight that it is because uterus, a term uterus, receives blood supply at a very high rate, that is 700 mils per minute. So for a woman to exsanguinate, it doesn't take much time. So within 7 to 8 minutes, if you are not aware of your management, you can lose the life of a woman. And it can happen to anybody in any place. We have all seen from rags to riches, people have died because of obstetric hemorrhage. So whereas we always think that this is the safest place to give birth, we must be aware of the fact that disasters have no place. Everybody should be equipped with the knowledge of management of postpartum hemorrhage, be it a corporate sector, be it a private sector or government or a rural sector. And that's because if we do not recognize what is happening, which is always the case, and we land up in too little is done too late. And this mostly happens because, as already highlighted by ma'am, that we fail to diagnose because of we are not able to quantify the severity of hemorrhage. Most of our places do not have proper protocols in place, and we also lack training in many of our centers. And then we also have some treatment failures like uterotonics, the use and the dose. What should be the correct dose? Sometimes you do not know what uterotonics to be given in this kind of patient. And then we also delay our decision to transfuse blood and blood products. We go ahead with more of crystalloid solutions, which can pose more problem than solutions. We do not understand the clinical science, and we do not order the labs properly and timely. And this contributes to failure in our decision making, and ultimately it ends up in an obstetric disaster. In some places, there are even structural failures, like there may be lack of adequate equipment because of the area where you're working, as has been already highlighted by ma'am, that how deficient we are in our anesthetic requirements in many places. There are teamwork errors, like if you do not conduct team meetings, then you can be on a different foothold whenever you are having such a disaster. And this can also lead to communication failures. So we also need to strengthen all these things before we start thinking of management of PPH. Along with this, we have the background of a mother who undergoes physiological changes. And we all know that the physiological anemia of pregnancy, higher blood volume, and increase in plasma volume all contributes to, delayed presentation of hypovolemia. And most of the women have lost about 25 to 30% before they start showing up. And this is one of the major reasons why we tend to think that this woman does not require blood and blood products. And we tend to miss our initial clinical signs. The other thing which is very, very important is that in postpartum hemorrhage, the coagulopathy is of a different nature. And it is not the same as what we see in trauma or in other settings. And it is especially so if it's an abruptio, AFE or PE. So this has to be kept in mind that it is not the same as what happens in the other settings. And what you have to remember further ahead is that fibrinogen depletes the earliest. And this has been shown in the latest literature as I've highlighted. Along with that, we must also be aware of some risk assessment tools. As such, you cannot predict which woman is going to be at risk of bleeding, but there are some women for which we should be alert. And this has been studied by 3 societies, like the Society of Women's Health and Obstetric plus Neonatal Nursing, ACOG, and even California Maternal Quality Society, CMQCC. So what they have said is, like, if you find that the woman is at high risk, which I'll be talking in the next slide, you should know what kind of lab tests you want, what kind of cross-match and screens you want, and that should be recommended based on the specific risk categories. So these are the risk categories of which I'll be, specially highlighting the ones in which you should be warned. Like if the woman has had 4 previous vaginal births, or there is a previous scar, large fibroids, previous history of PPH, chorioamnionitis, fetal demise, importantly, morbid obesity, and estimated fetal weight of more than 4 kgs. Or if the patient is having active bleeding or suspected accreta or procreta, placenta previa, known coagulopathy, and then again more than 1 previous PPH, anemia, or thrombocytopenia. So you should know if your patient is suffering from all these things or is having all these things. 2 or more medium risk items classifies these women as high risk. So if you come to know that the woman is at high risk, we have to come forward, as has been highlighted very nicely by ma'am, that anesthesiologists need to speak. They need to be shown these women early on. Women should not be shown on the table when the disaster is happening. We must be aware of our own patients by doing a proper pre-anesthetic checkup and preparing with other team members. For example, for placenta, accreta and procreta, we all know that we need a team of people who can work in deep pelvic areas. Like we should have a surgeon, a trauma surgeon, and a urologist. And the team should not be confined to only one gynecologist, obstetrician, and an anesthesiologist. So the risk assessment is a very important tool in management of PPH. Along with that, whenever the blood losses are turning greater than 500 mils, you should be warned if there are some red flag signs like tachy more than 100 beats per minute in spite of balanced volume and adequate pain control, hypotension or 20% drop in blood pressure, patient is turning restless, as was highlighted. You should listen to your patient. You should not think that she is malingering, and we should look at inappropriate responses. Look at the shock index, which is like a heart rate divided by the systolic blood pressure. Do blood gases and look at the lactate values and the base excess values, which tell you with decreasing base excess and increasing base excess, you come to know what is the blood volume lost. And then if the patient is not having adequate urine output, we must be aware. And of course, coagulopathy, if it is setting in, we should be able to detect it either clinically or through viscoelastic testing. So if the blood losses are more than 1 liter, we must be anticipating, or we must be thinking about PPH. If PPH is happening, then we have to trigger a massive hemorrhage protocol. So we have to understand that we are not talking about massive transfusion protocol alone. We are talking about massive hemorrhage protocol, which is a 7-point agenda. Like you have to inform that this lady is bleeding. Then your team has to be prepared. you have to have hold over tranexamic acid. You should do testing of your patient, lab testing every hourly, and you should set some targets. You should not just continuously keep on transfusing. You should know when to stop, and proper temperature management. And then last and least of all, you should know that now my patient needs termination of the protocol, because you have started a chain of events. You have involved so many people. So you need to tell them that halt. Now the patient is stable. So this is called massive hemorrhage protocol, which encompasses all these points. The first step is, which is very, very important, is ask for help. So when you ask for help, you must know that you have to tabulate it as well. So when you recognize, call for assistance, you designate a team leader, the one who gives orders further, and then a checklist, a recorder, then somebody to calculate the cumulative blood loss, somebody to look at the vital signs, and then determine what stage of hemorrhage this is. A very important step is to classify your hemorrhage based on the 4 classes of hemorrhage. We should not say patient is bleeding. We should know it's a class 3 hemorrhage, class 4 hemorrhage, and the details of that can be seen on ATLS website. So we all know that the cause and approximate incidence of postpartum hemorrhage is maximum with atony, and atonic uterus is accounting for majority of PPHs. The others we all know are trauma, tissue, and thrombin. And the standard protocols, I'll not repeat here, are using oxytocin, methergin, and then you go on to carboprost and then misoprostol as indicated. What we as anesthesiologists should ensure is that we have 2 wide-bore IV accesses, and we have warming devices, as I'd already highlighted, to ensure normothermia. And we should also take care of preoperative antibiotic prophylaxis, and more so if the surgery is prolonged. Then IV volume replacement should be done with crystalloids only initially, and later on we should transfuse blood and blood products. Must remember to do lab investigations. So because all your resuscitation should be a guided protocol. It should not be a random thing that whatever is there with us, we are going to use that. So now the dictum is goal-directed resuscitation. So for that, you have to send for certain lab investigations, like do serial hematocrits, look at ionized calcium, potassium, creatinine, and ABGs. And for coagulation testing, we should send platelet counts, prothrombin, partial prothrombin times, and fibrinogen. So basically, these are a combination of both, standard lab tests as well as the point of care tests I'll be talking about in the next slide. So why we are laying so much of emphasis on fibrinogen is through this multicentric trial, which was conducted by Charbit et al. It's a very famous trial, that is why I put it up. And in this trial, it is a multicentric trial involving 128 women, where the study's objective was to determine whether changes in hemostasis markers during the course of PPH are predictive of its severity. And they found that fibrinogen was the only marker associated with the occurrence of PPH. At 0 time, that is the time when they started enrolling, the risk of severe PPH was 2.63 folds higher for each 1 degree decrease in fibrinogen. So this is a very important thing which we must understand, that in obstetric patients, it's very important to keep fibrinogen levels at or more than 2 grams per deciliter. And this is one graph in which they have shown that 4 grams per liter has the maximum sensitivity and specificity to predict bleeding in a patient who's having PPH. So it's very, very important study, which we must all be aware of. So when we talk about how to resuscitate, the sequence has been reanimated now, and it is like hand in hand, red blood cells, FFP, and platelets. So mostly massive transfusion protocol follows the dictum of 1:1:1. That is 1 red blood cells, 1 fresh frozen plasma, and 1 platelet. But now some studies are coming up in which the ratio is going from 1:1 to 2:1. And finally, there are some school of thoughts which are now advocating that we can wait for platelets transfusion till they fall to less than 50,000. In my own institute, I have found out, and most of the practice is to give 1:1:1, because most of us are not very, very tuned to not giving platelets. But having said that, if you are not having platelets, then the loss of platelet happens later on. The first thing to decrease in a bleeding patient in pregnancy is fibrinogen. So if you give red blood cells and fresh frozen plasma or fibrinogen substitute, that would suffice the problem. So when we talk about calcium, calcium is now, everybody is now well aware that calcium is central to many things. Like if patient is not maintaining temperature, is hypothermic, it causes a decrease in liver metabolism of citrate, and that is not, citrates are not metabolized in the liver. So you get less calcium, and then calcium is integral to so many steps in coagulation pathway. If you do not have calcium, then the clotting is also affected. Same way, we know that when we are transfusing too much of blood, hypocalcemia does ensue. And if acidosis is there, then low calcium levels are associated with low pH. So we need to really bring it up to at least more than 0.9 millimoles per liter. So kindly be sure that you have calcium at hand when you are looking after postpartum hemorrhage. So FFP, as I earlier alluded to, is not ideal for managing hypofibrinogenema of PPH, as it contains very low concentration and requires administration of high volumes. If you give high volumes of FFP, that predisposes the woman to transfusion-related circulatory overload and infections. So if we have to do large volume resus using FFP, it would be a good idea to use fibrinogen, which replaces your fibrinogen levels much faster than the FFPs. So when we talk about standard lab testing or point of care testing, so we normally do send our PTT and APTT, but literature has shown us that in pregnant women, they remain normal despite huge blood losses up to 5 liters. So they're not very predictive. It is, and it takes about 60 minutes for your standard lab test in a well-functioning institute to come back to you. That is the turnaround time. And we all know that PPH is very, very dynamic. The situation changes every 15 minutes. So what test you sent 1 hour back may not be translatable to the patient at that point of time. So what can we do then to avoid, problems? So as I've already said, we can go ahead with the viscoelastic testing, in which ROTEM is now figuring in as better than TEG. So you can come to know about the fibrinogen deficits, and accordingly, there's an algorithmic approach. You can use that algorithmic approach, which is given with all the ROTEM machines, and accordingly, you can transfuse. So this again speaks about guided protocols, as we are mentioning, that do not give things which are not required, give things which are required. So we need to give fibrinogen. We know if FIB-10 is, less than 12 millimeters, then we have to give what, and so on and so forth. So, and to tell you all, fibrinogen is now available in India. It's been being marketed by 1 or 2 companies. One of them is Intas. So it is available as Ryostap with one of the companies, and it does not require thawing, but it does require water for dissolving, which is not available with the package. So you can reconstitute the solution, and it contains 20 milligram per cc of fibrinogen, whereas cryoprecipitate has lesser, 10 milligram per cc, and FFP has even lower. So the dose recommendation ranges from 30 to 60 milligram per kg body weight. So you can calculate the doses and you can reconstitute and give. The cost in India is somewhere around 15,000, but I'm told for Ayushman patient, it is even lesser. So we are all aware of tranexamic acid and its effect on a patient who's acutely bleeding. This has come from the women's trial, which was published in Lancet in 2017, in which they show a definite benefit of giving tranexamic acid to those patients who were acutely bleeding. And so what actually tranexamic acid does is that it actively inhibits the binding of lysine with the plasminogen and doesn't let the conversion of plasmin happen. So it prevents the clot lysis. So it was invented way back in 1962, and it was shown by these authors, Yutako and Okamoto, that it prevents excessive bleeding. So prophylactic role of tranexamic acid is not as proven as the one for a bleeding patient. The typical doses are 1 to 2 gram, which can be given as infusion. If the woman continues to bleed, it can be repeated at 6 to 8 hourly. So this is again the same thing which I've just spoken. So for factor replacement, we also now get prothrombin complex concentrates, which contains the vitamin K dependent factors like 2, 7, 9, and 10, and protein S and C. But whether PCC has been substantiated by any clinical trials, we are awaiting more trials on this before we can say that, yes, octaplex is also good enough to be used. So recombinant factor 7A has been recognized for treating a refractory PPH, but for using factor 7A, there are certain prerequisites which are mostly very difficult to meet. That is fibrinogen more than 2 gram, platelets more than 50, temperature and pH. It's very difficult. So you have to as case-by-case decision and not as a routine. So talking about the best strategies to manage your hemostatic and transfusion in a PPH. So you have to have basic preconditions like a normal temperature, normal pH, and a normal calcium. You can consider cell salvage, but it has its own disadvantages despite being very expensive. Antifibrinolysis should be considered in a patient who's acutely bleeding. Try to do point of care testing using blood gases and TEG and ROTEM. Lab tests can also be ordered, but they take a lot of time, and PPH being a dynamic may not correlate to that point of bleeding in that particular woman. If you're doing transfusion, try to do reanimated resus with massive transfusion protocols with RBCs, FFP, and platelets. And the target should be to keep hemoglobin above 7 grams. 9 grams is good. Platelets more than 75 to 1 lakh, fibrinogen 2 to 2.5. And then if the patient has having refractory bleeding, you can consider factor 7A in the presence of prerequisites, which are what I highlighted. But do also remember that there will be some women who will require the help of interventional radiology for knowing the site, knowing what site is bleeding and plugging that hole. Patient may also require an emergency OR for a peripartum hysterectomy. And then there are post-operative morbid conditions like acute kidney injuries, sepsis, and DIC, for which you need to refer the patient to a higher center. So if you have any patient who is at risk of bleeding, you have identified early, it's better to shift the patient to a higher level of maternal care, which was talked about in the previous lecture. There comes the importance of doing a proper antenatal checkup and being a part of the team right from the antenatal period, rather than pitching in when the patient is already bleeding and there is blood pooling on the floor. Also, we need to know the standard protocols of our own institute, of our own center, of our own rural setup. We must do regular audits on the women who did not fare good after an episode of postpartum hemorrhage. We should actively conduct PPH drills, which doesn't take much of resources. It just needs your mindset. We must also have ways to prompt and adequate therapy. Must use tranexamic and fibrinogen, and monitoring should be stepped up using viscoelastic testing. We must be aware of the latest guidelines on the use of uterotonics. With this, I end my talk, and I bring greetings from my institute, Postgraduate Institute of Medical Education and Research, PGI Chandigarh.
Thank you very much, Dr. Kajal. And now I invite Dr. Akila from SRMC Chennai. Dr. Akila, are you there?
Yes, ma'am. Yes, ma'am. I'm
Yes.
there, ma'am.
Yes.
I'll start sharing my screen.
Hello, this is Dr. Balani. Can you hear me?
Yes, Dr. Bhavani.
Yeah.
We can hear you.
Yeah.
Good. Sorry, I was busy with cases. I'm just in between cases. I wanted to congratulate the Indian College of Anesthesia and all the speakers, and such a great job for this 200th webinar. And I have 2 babies I'm taking care of here in between cases, but congratulations. The speakers have done a great job so far whenever I've been able to listen, but congratulations to everybody, ICA, the executive team, the members. Such a good job of the 200th webinar since we had COVID. So great job.
Thank you, Dr. Balani.
Yeah.
Yeah, we'll proceed with Dr. Akilandeswari.
Sorry for the interruption.
No, it's okay. Thank you.
Am I audible? Am I audible, sir?
Yeah, you're
Yes.
audible, Akhil.
Yes. Yeah, thank you. Good evening to one and all, and I would extend my thanks to Indian College of Anesthesiologists for giving me this opportunity. And we've listened extensively to Dr. Kajal Jain talking about obstetric hemorrhage, which is one of the dreaded complications. And now we'll go to the next obstetric disaster. I'm sure every one of us during our career will be stuck with 1 or 2 cases every month. A gravida with convulsions and altered mental status. When you look at the spectrum of the disease, about 15% of pregnancy we have will have hypertensive disorders of the pregnancy, and out of which around 2% of them will have severe preeclampsia, and there is an incidence that they may progress to eclampsia when they have severe features. We all know that. So looking at the outline of my talk, how do you approach a convulsing mother? What is the immediate and the supportive care which you're going to give at the site of convulsions? It could be an antenatal ward, it could be an obstetric suite, or it could be in the labor room. So what are the options available, and how is your system tuned to this emergency? And the next thing is treatment and prevention of convulsions, and care during operative delivery, and what are the critical issues and concerns while treating a patient who has convulsed recently. Why should you take this convulsions a serious issue? Because it is associated with maternal hypoxemia, and the hypermetabolic state can induce fetal hypoxemia because of maternal hypoxemia and hypercarbia, which results following a convulsion. In addition, most of the time when you look at these patients, and the blood pressure increases also can cause further compromise on the fetal well-being. So how do you approach a patient with convulsions in pregnancy? The first thing we have to do is to support airway, breathing, and circulation, and prevent maternal injuries which are occurring due to convulsions per se. As I told you, the site, the mother could be anywhere, and so we have to prevent harm to the mother and injuries to the mother during the phase of convulsions. So make her, you just rotate. This is the first step in addition to protecting her airway, breathing, and circulation. The next step which we have to focus is to prevent recurrence of seizure, and you treat the seizures which is occurring. The next one is you are able to optimize the reversible factors which are associated with seizures, so that the well-being of the mother and the fetus is protected at all times. These should be the guiding principles based on which you approach a patient with convulsion, and the top priority should be stabilization of the mother. So how do you, during the immediate phase, which could be anywhere between 0 to 5 minutes, make sure that the mother is placed in the lateral decubitus position. This will ensure that she does not aspirate. You are able to clear her secretions using a suction catheter easily. And the next thing is at the same time, you're ensuring maternal uteroplacental blood flow in this position. Next thing you do is you avoid soft tissue injuries to the airway by placing a soft airway to the gut to open up the airway if the patient is obstructing. Then clear secretion, as I already told you, and maintain the airway patency using jaw thrust. So an oxygen by mask, using a rebreathing mask or a reservoir bag mask should be used so that 100% oxygen is given to these patients so that you continue giving oxygen because they are at a risk of desaturation. The next step is, as I told you, it is prevention of maternal injuries, moving them to a safe location so that you avoid skeletal injuries and muscle injuries and soft tissue injuries due to the convulsion. This should be our priority when the patient is convulsing. Meanwhile, so in order to achieve all this, you need a team, you need mechanisms to activate the response teams, and you need drugs and equipments to deal with the scenario. So make sure that your obstetric, as an obstetric anesthesiologist, you have trained your personnel, technicians, and your staff nurse and your residents to by repeated simulations or by repeated educational simulations which you can do every day in the OR so that you, whenever this event occurs, you are in a better position to handle the scenario rather than putting the patient in a chaotic situation. Next thing, next 5 to 15 minutes will be so this seizure is usually self-limiting and it just stops within 2 to 3 minutes of after the seizure. So meanwhile, you get ready with your monitors, which the response team is bringing, connect ECG, monitor your blood pressure, find out what the oxygen saturation is, and continue giving oxygen support. This is very important. And initiate magnesium sulfate 4 to 6 grams bolus IV, followed by a 2-gram infusion. This bolus injection is very essential, irrespective of the type of, even when you don't know the diagnosis. I think magnesium sulfate should be given once, assuming that the patient is a eclamptic seizure, because that takes priority. The complications of not giving magnesium are more rather than overdoing it. So it is better to initiate magnesium sulfate once the patient starts convulsing, as eclampsia is the most commonest cause. The next priority will be control of your hypertension, because this is the phase where you will be taking care of your blood pressure, and there can be fetal monitoring if you want to see how the well-being of the fetus is. And it is very important that you do it after 10 to 12 minutes of the seizure, because transient bradycardias are known to happen during this immediate phase after the convulsion. So you wait, which will resolve once the seizure stops, and then you're continuing to give oxygenation because of your ABCs. The fetus is going to be normal. So the heart rate changes will settle after 10 to 15 minutes, and you take a decision for operative delivery only when there are persistent beyond 15 minutes. So that is the point which we have to remember. And meanwhile, you send investigations which can include your complete blood count, metabolic parameters, coagulation profile, and cross-matching of blood, because they are more prone for bleeding. Once all these are done, it is very important you evaluate the patient for her neurological status. Most often, the postictal phase lasts for a very short duration of time. So, and they will recover without any neurological deficits if it is a eclamptic seizure. This recovery of neurological status is very important in case you have to find out what are the deviations that are occurring following delivery and following general anesthesia. So this evaluation of neurological status becomes mandatory prior to anesthetizing the patient. So when you look at when you look at the incidence of eclampsia, it is around 1.6 to 10 per 10,000 deliveries in the developed countries, and it is around 50 to 151. It's very high, and this is because of inadequate screening which we're doing to capture patients when they are at the severe preeclampsia level. And when you look at the maternal death, it is quite common in eclampsia, and the complications related to eclampsia are quite a lot. You have cardiac complications, you have cerebrovascular complications. The incidence of hemolyte HELLP syndrome is around 12% with eclampsia, and and they can go in for disseminated intravascular coagulations, venous thromboembolism, and the need for transfusion, multiple transfusion. All these will coexist in a patient who is eclamptic. So the incidence is quite high. In addition, the incidence of aspiration pneumonia following a seizure is also going to contribute to your disordered respiratory status. So this is the reason you have to treat them early. You have to pick them up early and then give magnesium so that there are no recurrent convulsions, and then you act accordingly. When you look at the therapy for magnesium, it is started at, as I told you, at 4 to 6 grams bolus IV and should be followed by 2 grams per hour infusion. And in case of recurrent convulsions following the first episode, you repeat a bolus dose of 2 grams over 5 to 10 minutes. And if the patient has pre-existing renal failure in the form of elevated creatinine levels, then it is not necessary to reduce your bolus dose, but just reduce your infusion dose alone to 1 gram per hour, which you really have to keep in mind. So do you need to monitor serum levels when you administer magnesium? Not at all. You just monitor the clinical status of the patient and especially look for deep tendon reflexes. Even after the seizure episode, after all, what they are going to have is exaggerated deep tendon reflexes. And so when you give magnesium, the absence of deep tendon reflexes indicate that the patient is going in for toxic features, and you can reduce the dose. That is how it is an easy method of monitoring the magnesium therapy rather than looking at serum magnesium levels. And once started, this magnesium should be continued for at least 24 to 48 hours, and definitely for 24 hours, especially from the last episode of convulsions. It is very important that the entire team is educated that you do not stop infusion based on your blood pressures if it is on the lower side, or it is not used as an antihypertensive agent. And next thing is, during induction of anesthesia, it can cause fluctuations in BP, it can cause hypotension, which should not be the basis for stopping magnesium therapy and for fear of the hypotonicity of the uterus. Once the patient has eclampsia, the magnesium should never be stopped for the next 24 hours. That is the main take-home point with this thing. And how do you ensure that the magnesium infusions are given in the safest possible way? Use a dedicated line which is exclusively for magnesium, so that because it is a high electrolyte solution. The next thing is use high alert stickers with labeling so that it is not accidentally rushed during the process of shifting. And handoff communication during transfers between ward is very essential when the patient is on magnesium infusion. And this also avoids accidental purging of large doses of magnesium, which can result in bradyarrhythmias, and where you have to stop the need for stopping magnesium arises. So these methods should be followed. And following post-seizure management, following the administration of the magnesium, the next thing to focus is stabilization of your blood pressure. Your target blood pressure should be a systolic in the range of 140 to 150 and diastolic around 90 to 100. And this is to ensure that there is end organ perfusion which is maintained. At the same time, you prevent cerebral hyperperfusion related complications. And of course, we have why is there a need to optimize this blood pressure? Because following a convulsion, we know that the blood-brain barrier is altered and there is dysregulation. There is also microglial activation which causes vasogenic edema and cytotoxic edema. So under treatment or undertreated blood pressures can aggravate these things and result in hemorrhagic stroke, which might be the one which is attributed as one of the leading cause of death in patients with eclampsia. So the other thing which we have to notice, intracerebral bleeding in pregnancy occurs at much lower blood pressures. So it is very important you maintain your target pressures by optimizing your antihypertensive medications. And we know that these are the regular drugs which we use. And of course, in India, we are using labetalol, and nifedipine has been one of the most regularly used drugs. And remember that magnesium is not used for blood pressure control. Looking at all these things now, if there is an now the next priority would be to urgently deliver the baby within 24 hours. So that is the recommended thing. Though the recommendation is for 24 hours, I don't think we routinely wait for 24 hours. It is often taken once the convulsion stops and we are ready with everything. Most often the patient is wheeled inside the OR. So what are the challenges which you face when your patient comes to OR for an operative delivery? We know that the physiological changes in pregnancy put them at a risk of desaturation. In addition, there are pathophysiological changes secondary to pregnancy-induced hypertension. And because of this convulsions, your upper airway edema can get worsened. There can be tongue swelling or tongue biting, and then there can be bleeding from your upper airway, which can cause a difficult laryngoscopy. And the additional comorbidities and the stature of the patient can further add to the difficult airway, which we have to keep in mind when anesthetizing this patient. So difficult airway can occur at multiple stages of management during giving GA in these patients. They are prone for desaturation, we know that. In addition, when you look at the alveolar level, the incidence of interstitial edema in the form of pulmonary interstitial syndrome is going to be very high in these patients. So a minor surge in blood pressure or an increase in heart rate can, because of the diastolic dysfunction, you will be pushing these patients into frank pulmonary edema. What was interstitial edema could become a pulmonary edema during the process of securing the airway. And then there is impaired gas exchange and reduced alveolar volume and functional residual capacity, which occurs in all pregnant patients, and more so in patients with pre-eclampsia and eclampsia, and the hemodynamic response to intubation, which already I have told you. The next thing which we have, there can be micro aspirations and aspiration of gastric contents, which can cause a decrease in saturation. So it is very important that the basal pulse oximeter value, what is it prior to anesthetizing this patient, because that tells you, like, even if there are no facilities to get an arterial blood gas analysis, that is going to tell you that the patient has got some amount of micro aspiration or aspiration prior to induction of GA. So what are the steps to prevent desaturation? You pre-oxygenate, manually ventilate with 15 to 20 centimeters of pressure, and use liberal use of drugs to attenuate the hemodynamic response with fentanyl, and inform your pediatrician about this. And short-acting beta blockers definitely are indicated, and bolus NTG increments should be kept so that you don't push your patients into interstitial syndrome. In addition to all this, successful intubation at first attempt by using the senior-most person intubating it and using a video laryngoscope or a smaller tube with a stillet is at most important. Within 30 to 45 seconds will help in preventing these hemodynamic response, in addition to usage of all these drugs. So it should be a combination of drugs, equipment, and personnel, which helps in always securing the airway at the first attempt in such challenging patients. The next thing which we have to remember is, it's very important that you put you do not rush fluids in these patients, and it should be a restrictive regime inclusive of all the infusions which you are giving, and anticipate and titrate according to the blood loss, intraoperative blood loss, using your dynamic indices, for example, your pulse pressure variations or systolic pressure variations based on the arterial blood pressure. And use of ultrasonography will help you to pick out interstitial edema prior to the onset of desaturation. Now, when you look at the uterotonic usage in these patients, we know that compared to non-laboring patients, laboring patients require higher. And it has also been shown that compared to normotensive patients, the pre-eclamptic patients require a higher dose of uterotonic drugs. And there is a study where they have quoted the mean dose of the ED95 dose of oxytocin is around 24 international units per liter compared to 10 to 12. And though the incidence of hypotension is comparatively lesser, with even with this higher dosage of syntocin. Next, during extubation of these patients, you take a cautious call depending on the neurological status of the patient at the time of induction, and then the level of difficulty faced during intubation, and use the neuromuscular monitoring guided reversal agent so that they don't have residual neuromuscular blockade, and ensure During your extubation also, you are taking precautions to prevent surges in blood pressure. This is very essential because post-extubation pulmonary edema is also one of the commonest things. When we look at the neuraxial blockade in these patients, it is often we would have read in our books, and what is being suggested everywhere is if the patient is conscious, oriented, without any neurological deficits, and if your platelet counts and coagulation profile are normal, that is within the 6 hours, then you can go ahead with the neuraxial blockade. But what we, and when you look at the guidelines for placement of spinal and epidural catheters, these are the recommended things where when your platelet count is more than 70,000, you are justified, and 50 to 70 you take based on the risk benefit ratio. Now, in addition to the risk benefit ratio of airway and the complications, now when you think about a patient with eclampsia, it is a dynamic coagulopathy. That is point number 1. And the incidence of HELLP syndrome is going to be quite high. The incidence of postpartum hemorrhage is going to be high. So it is better to always, and the neurological status and the complications and the autoregulation which happens following intrathecal puncture, we have to take all these into consideration before just saying that it is a neuraxia is a better choice of anesthesia in a eclamptic patient. I would say GA would be a much safer option. Having known about all these complications, do we have any biomarkers recently for progression and prediction of severity? It is at the level, though it is not included in the guideline, they have shown that low level of placental growth factors, less than 100 picograms, are associated with severe adverse outcomes in preeclampsia, especially with onset of eclampsia can be predicted with these things and HELLP and cardiac failure. So look at having said eclampsia is one of the commonest cause. There are other disorders. For example, the patient could have a pre-existing seizure disorder, which could be the cause of seizure. And whenever there is a new onset of seizures, it could be related to other than eclampsia, Press syndrome, cortical thrombosis, or other things like autoimmune disorders. Having Hapla syndrome and Dr. Akila, you're not audible. Dr. Akila. I think she has been logged out.
She must have lost the internet connection probably.
Yeah. So,
Hello, Seda.
yes.
Hello, Seda or Clarinet. Are you there?
Dr.
Dr. Sanish. Dr. Sanish or Dr.
Sir, I think an internet connection problem at that end.
Acha. Okay, now it's back.
Sir,
Not
can
yet,
we
not
have
yet.
Dr. Delani's felicitation, or is it over?
That's over.
Okay. So then do we go on to Dr. Sunil Pandya?
I think we'll wait for a minute. I think later, I think she must be trying. Can we reach out on her phone whether if she's getting?
Sanish, are you? Yeah.
Sanish, could you connect to Akilandeswari? Yeah.
I just talked to Dr. Akila. She says she's reconnecting.
Yeah, okay. We'll wait.
I think, ma'am, we can have the question that has been put in for the audience because Sanish said that probably they wouldn't be able to read our chats.
Okay.
This is a question which says, can we give subarachnoid block in patients who had seizures and has recovered?
I think
If
Kajal and
other, I think they did reply, but because the audience cannot access our chats, we can perhaps answer it for them.
Yeah. So, Sunil, can you answer? Because Akila is not there. You could
post
answer.
post eclampsia, we just have to assess the clinical status. If there are no any focal neurological signs like hemiparesis or lateral rectus palsy or anisocoria, GCS is good. Platelets are more than 70,000. Then regional is a safer choice and a better choice than a general anesthesia. Even the incidence of perioperative post-spinal hypotension incidence is less, and the best neurological monitor is awake, well-oriented patient. But yes, if the patient is having obtunded neurological status, irritable, drowsy, then better to have a tube in the trachea and ventilate and achieve normal gases, and post-operatively before extubate, reassess the fitness for extubation, and you need be subject the patient for radiological imaging before you plan for extubation. So to summarize, post-eclamptic seizure, spinal is a safe bet compared to general anesthetic, provided GCS is good and there are no lateralizing sign. Many times GCS is 15, but they may have lateral rectus palsy. GCS is 15, but they may have hemiparesis. So you just have to do a good bedside neurological assessment and then take a call.
So I think Akila is not able to connect. There are no other questions, Anju, in the box, I think. There was only
No,
one.
ma'am. There was only one question. Yeah.
So maybe we can start with Sunil and she can continue after you complete.
Can I share my screen?
Yes, Sunil, you can start.
My screen is visible. Am I audible and visible?
Yes, Sunil.
Yes, yes.
Good evening, all. At the outset, I would like to congratulate ICA executives for the fantastic journey of 200 weeks of continuous webinars. And thank you for this opportunity. I'm coming on the ICA platform for the second time. I think first time myself and Ravi, and we are there on the obesity seminar with Dr. Baljit. So coming to my today's talk, they have given me the topic of stat cesarean section in a cardiac compromised parturient. Again, nil conflict of interest. And because it's a cardiac compromise, I shall be emphasizing only on class 3 and class 4 cases. And I shall be discussing our experience and the current evidence that we have had in management. If you look at the maternal morbidity and mortality in India from the cardiac disorders complicating pregnancy, this is the data from Kerala, Dr. V.P. Piley and team. Uh, cardiac disorders complicating pregnancy are the sixth leading cause of maternal mortality in our country, at least in Kerala, and probably it reflects our country as well. Yes, of course, preceded by hypertension, eclampsia, and sepsis. But importantly, just to review our data from Fernandez Hospital, this is of course an old audit 2020, but 4 to 6% of ICU admissions in our hospital are because of cardiac diseases complicating pregnancy. So when we talk about cesarean sections, there are different categories, and Dr. Radhakrishnan and team has given me the stat cesarean section. And the stat cesarean section, nothing but category 1 cesarean section, where continuation of pregnancy is a threat to the mother or the fetus, and the pregnancy has to be terminated, and the mother has to be operated immediately. Otherwise, it's a threat to the mother or to the fetus. And unfortunately, cardiac compromised patient can also be morbidly obese patient. And if it's a stat cesarean section in a morbidly obese patient, things can become dicey. And if the mother has pathological spine, again, it can add to the further problems. And converting labor epidural to in a cardiac parturient cesarean section is always an emergency, and it can also become tricky. And yes, sometimes the stat cesarean sections, if we give regionals, you may end up with failed spinals and difficult airway, which can also add to the problems. And of course, unanticipated major obstetric hemorrhage is not uncommon in cardiac parturients, including perioperative hysterectomies. And of course, hemodynamically unstable parturient requiring mechanical ventilation, hemodynamic supports, assist devices, ECMO support, or cardiopulmonary bypass. Well, these are all the things that we have experienced, and I should be touching upon a few of these things during my talk. So just a brief about what categories or what are the categories within this section for the benefit of postgraduates. We are emphasizing on category 1 section, which is a emergency cesarean section where the continuation of pregnancy any further is a threat to the woman or the fetus, and pregnancy has to be terminated. Conventionally, at the decision delivery interval has been fixed as the holy grail of 30 minutes, where the once a decision is taken, the baby has to be out within 30 minutes to enhance the metal condition or to improve the fetal condition. And of all the emergencies that we have in obstetrics, 60% are obstetric emergencies, but only about 7 to 8% are true category 1 sections. So remaining 52% of emergency sections are category 2 or category 3, where you can have your own sweet time to give a safe regional anesthesia, because we know that regional anesthesia is a safe bet in obstetrics for any comorbidities, provided there is no contraindication. So when you discuss about anesthesia considerations in a parturient for stat cesarean section in a compromised patient with a cardiac disorder, the thing that we need to consider is what is the type of cardiac lesion that we are dealing with, and how are the metal hemodynamics? What is the influence of anesthetics on the hemodynamics? And we have categorized category 1 cesarean section or stat sections into a subcategory, I would say, into category 1A and 1B. These are our personal classification, our team's classification. I shall be coming to it a little later again. But importantly, we are dealing with a high-risk mother and a high-risk fetus. So we need to be very judicious. Importantly, before we consider about anesthetizing this parturient, especially 80% of deliveries happen in nursing homes, at least in our country, or in a district general hospital or a semi-urban setup. So we need to look at the infrastructure availability, the competence of the personnel, and the ability to have a multidisciplinary backup, because these parturients, when they destabilize, they require multi-organ support, multidisciplinary care, including emergency cath interventions, or sometimes cardiopulmonary bypass and valve replacements, or coronary interventions as well. So we need to consider all these factors before we plan anesthesia. Classically, the pentad of high-risk cardiac parturients include critical mitral stenosis, where the mitral valve area is less than about 1 centimeter square, or mitral stenosis with atrial fibrillation, LA size of more than 4.5 to 5 centimeters square, with or without LA clot. Severe aortic stenosis, gradient of more than 45 to 50 millimeters of mercury. I'm talking about the pre-pregnancy gradient, because all the gradients during delivery or during pregnancy, they increase. Any type of cardiomyopathy with ejection fraction of less than 40% is considered as a high-risk cardiac lesion, or a Marfan syndrome with the aortic root dilation of more than 4.5 centimeters, because they are prone for dissection at a very low threshold of one episode of hypertensive crisis. They can end up with dissection and sometimes cardiac tamponade also. And pulmonary hypertension with either secondary or primary are all serious conditions. So again, before we discuss about anesthesia, we need to know, is this stat cesarean section because of the cardiac issue? That means, is the patient is in heart failure? And does the mother require maternal resuscitation before we take her up for cesarean section? Very, very important, because do not rush an unstable mother for urgent delivery, because you are further going to destabilize, and sometimes you may end up with mortality. Or it is a perioperative cesarean delivery. I'm not going to touch upon this topic because Dr. Anju is going to talk in detail. Or it is an obstetric cause that is causing stat cesarean section. And is there a need for intrauterine fetal resuscitation just to buy time for to stabilize the mother so that the fetus also is in a better condition? Or is there a need for steroid, whether can we wait for the fetal lung maturity for about 36 hours or 24 hours or even 12 hours after the fetal steroid? So these decisions have to be taken, and we need to obtain a consensus so that we can give best to both the lives. Fetal cerebral protection also we need to consider, especially cardiac parturients, especially class 3 and class 4, NIHA class 4. They have the incidence of preterm delivery is almost close to 27%. And sometimes we have extreme low birth babies. And in these cases, whatever little cerebral protection we do by magnesium sulfate therapy is helpful. Sometimes you may have acute conditions like cord prolapse, uterine ruptures, and pathologic Romanesque CTG, which are the fetal indication for category 1 cesarean section. So when you have an unstable mother with unstable hemodynamics, always we need to resuscitate and stabilize and optimize the mother. And we need to understand the physiology, the parallel physiology in the fetus as well as the mother, because they for giving best to both the lives. And importantly, constituting a protocolized multidisciplinary team is very, very important. We need to remember that when there is a fetal indication, the important causes of fetal demise are hypotension, hypoxemia, and anemia. And when you have a parturient with maternal or cardiogenic shock, you have hypotension, you may have hypoxemia because of heart failure and lungs are flooded with water, and both can compromise the fetal well-being, and you may have to optimize and quickly deliver her in a safe condition. What we have in our experience, we have had a series of cases where we had to deliver on ventilator because of refractory pulmonary edema. We have had 11 patients of patients where we had subjected to mitral valve replacement or aortic valve replacement during pregnancy and delivered with bypass, or sometimes we continued the pregnancy after cardiopulmonary bypass and had a normal delivery later on. One patient we had to connect on intra-aortic balloon pump post-operatively for refractory hypotension because of coronary spasm and myocardial ischemia. We have had two patients requiring percutaneous balloon mitral valve commissurotomy because of, again, refractory pulmonary edema. Both survived with fetus. There was a fetal demise. One patient, we had to put the patient on VA ECMO. Unfortunately, the patient succumbed because it was very late referral. She was in severe shock. And one parturient, we had to do perimortem cesarean delivery. The mother survived, but fetus we could not salvage. And several cases of various class 3, class 4 NIHA cases, valvular heart diseases, cyanotic heart disease, acyanotic heart diseases, gooks, mechanical heart valves, cardiomyopathies, aneurysms, coacs, arrhythmogenic right ventricular dysplasias with refractivity, pacemakers, AICDs, VTs, and ICA makers we have anesthetized. Fortunately, most of them, they have good outcome. But importantly, as I said, these patients, they require high-end support. So before you plan anesthesia, see that the infrastructure is geared up to support these parturients. And yes, you need to have a focus skills also, because preoperative echo is very, very important. This was the case of peripartum cardiomyopathy with EF of less than 30% and regurgitation. So very, very important. Importantly, when the patient is in failure, non-invasive ventilation is a safe bet. And non-invasive ventilation in pregnancy is quite safe. The risk of aspiration is very low. And in fact, there have been a series of cases where we put an epidural, we put an IV, and mothers have delivered normally with the metal. You can see the metal fetal monitoring both under epidural delivering. So stabilizing the mother, improving oxygenation with non-invasive ventilator support, especially when the SATs are less than 94% despite high flow oxygen devices. NIV is a safe bet. CPAP pressure support or BiPAP, both are, but CPAP pressure support is a better modality of maintaining adequate oxygenation. And close to 1,200 cases we have. Of course, many of them are cardiac parturient. Importantly, when the mother is in frank heart failure, do not subject her, do not push her for cesarean section. Stabilization is very important, either with high flow mask, NIV, or sometimes you may have to put a tube and mechanically ventilate this patient with a PEEP and inotropes and vasopressors need be. Importantly, because the preload is reduced in supine position, you may have to keep the patient left lateral. Diuretics should be given at least 1 to 2 milligrams per kg. NTG infusion if the mother's SVR is very high, so that you can reduce the afterload. And of course, digoxin is used less and less now, but digoxin has been used conventionally for all most of the AF cases to control the rate. Not to because these patients are especially mothers who are on diuretics for long, more than 12 weeks, you need to monitor potassium and see that the supplement is always on, because the risk they are prone for hypokalemia, and you need to be careful. Restrict fluids. Again, you can have focus to guide your fluid therapy, but generally most of the parturients, they don't require fluids because we don't starve them enough because of the ERAS guidelines. We just 4 to 6 hours of starving is good enough. And majority of them, they require DVD prophylaxis, can be started preoperatively. And once the baby is out, postoperatively, ACE inhibitors are the drugs of choice to reduce afterload. They help in reduction. So coming to the choice of anesthesia, the choice I'll be talking what we practice in our hospital. The programmed epidural is the first technique of choice, especially patients who are compromised cardiovascularly. When I say programmed epidural, beside the epidural at L1, L2, or D12, L1, or sometimes L2, L3, the best space and the widest space. And we avoid soda bicarb so that we don't want a rapid onset block. We want a slow onset block. We always use lignocaine with adrenaline, and we always use fentanyl. So we just give 3 ml activation dose, wait for 3 minutes, and incrementally top up the patient and achieve a block of at least D4 to D5 so that the myotomes and dermatomes relevant for cesarean sections are adequately anesthetized and they can have a safe surgery with the minimal or no discomfort. The second technique of choice is combined spinal epidural low dose spinal. The low dose spinal is just about 5 to 6 milligrams of hyperbaric bupivacaine with fentanyl and 100 micrograms of morphine for postoperative analgesia. And subsequently, epidural volume expansion is done to achieve a block of D5 to D6. A word of caution: when you are giving sequential CSE, the epidural catheter is not tested. So, and importantly, when you do the volume expansion epidurally, do it at least after 10 to 12 minutes. Because if you are giving spinal and subsequently immediately injecting the epidural dosage to expand the volume, then the drug may not fix properly to the neuraxial tissue and you end up with high spinal. But again, we remember this is a stat cesarean section and we don't have that luxury of 10 to 12 minutes. So I'll be coming on this category 1 and category 1B a little later again. But importantly, just remember this point. We avoid single shot spinal in NIHA class 3 and class 4 patient, the very reason that the profound hemodynamic instability. But yes, if you're well versed with management of afterload, preload, contractility, rate and rhythm with pharmacological this thing, and you can circumvent the effect of spinals, circumvent the effect of spinal related sympathetic block, then you can give spinal anesthesia and do the pharmacological optimization by optimizing preload, afterload, contractility, rate and rhythm using different pharmacological agents. But in general, single shot spinal is not a technique of choice. Similarly, rapid spinal we don't practice in our hospital. General anesthesia is safe provided the patient is fasting, the difficult airway is not anticipated. And importantly, when I say general anesthesia, it is a cardiac GA. And when I say cardiac GA, it is a narcotic-based GA with minimal hemodynamic response to laryngoscopic intubation and extubation. But last 4-5 years, we have been blessed to have dexmedetomidine. It's a wonderful drug. We give a loading dose of 1 microgram per kg per minute in 10 minutes, and then continue the infusion at 0.25 microgram per kg per hour infusion throughout the cesarean section. And it does wonderfully. It stabilizes the laryngosympathetic response with minimal effect on neonatal effects. So if you have to give narcotic like 3 to 4 mg of fentanyl to obtain laryngosympathetic response, then you may have a risk of neonatal respiratory depression. So when we discuss about GA, it is always a cardiac GA, and preferably fentanyl based or dexmedetomidine infusion. Give magnesium sulfate 2 grams to suppress the laryngosympathetic response. Importantly, availability of rocuronium and Sugammadex has further eases out our recovery process from general anesthesia. We don't practice rapid spinal in our hospital. The very reason that single shot spinal is as fast as rapid spinal, there is no difference, at least in our setup. And continuous spinal, we practice only for the fellowship because we run fellowship courses. Fellows has to know, but otherwise we don't practice routinely. Local field block also is one of the technique in rural setup if you have a case, but we don't have any experience on this. Important aspect, other important aspect to consider is the postoperative pain management. So I was talking about category 1A and 1B. So if you look at this audit, the golden half an hour, the decision delivery interval of 30 minutes, is it a gospel truth? This was a fantastic audit from the United Kingdom where they have analyzed 17,780 category 1 sections, and they have divided DDIs in 15 minutes interval, and upbirths and stillbirths were also noted. And DDI of 15 minutes and less, there was no improvement in outcome when compared with those born within DDI of 16 to 75 minutes. So And this study or this audit was the basis for our audit, which we did. We did almost about 20,000 parchments we have analyzed retrospectively. And what we realized is only about 3 to 4% of women, they fall into category 1 section where the baby has to be out within 10 to 15 minutes. And those case sections like rupture uterus or cord prolapse without pulsations or ominous pathological CTG, that baby has to be out within 10 to 15 minutes. And remaining all category 1 section, you have 30 minutes to almost 75 minutes to anesthetize or plan anesthesia. And this we have put them under category 1B. So you just have to subcategorize so that you don't rush in a patient and end up with a difficult airway or a problem, especially morbid obesity or any of those things. Other important, this was again a CESDI, confidential inquiries in stillbirth diseases in infancy. The major reason for stillbirth was the lack of communication. And there was no poor communication, the delay in transfer the patient from labor room or from the emergency triage area to the theater. And nowhere in the CESDI report, there is a mention that there was a delay in anesthesia or providing anesthesia to this patient, resulting in stillbirth. So what I want to emphasize is, do not rush the patient just because it's a category 1 cesarean section. You need to redefine properly. This was our own paper from our hospital, where we have analyzed all the cord prolapses. Of course, these are not cardiac cases, but these are all cord prolapse. And one of the thing is, continuation of labor epidural for cesarean section, you could anesthetize within 7 minutes, the decision delivery of 7 minutes, single shot spinal 12 minutes, and GA was 10 minutes. Statistically significant, but importantly, when we look at the outcome of PH, the PH was better with spinal epidural compared to GA. So the point which I want to emphasize is, whether you give epidural or spinal or GA, the time taken is hardly any difference. So what I feel is regional is again a safe bet, and stat cesarean sections you just always have to take with a pinch of salt. There was one more study where they have realized or they have emphasized that the main delay for cesarean section was the transfer from labor room to the theater rather than administering anesthesia. So probably you need to put in a system where you can transfer the patient early to the theater and get a decent time to give safe anesthesia so that you don't rush in, especially in a cardiac compromised parturient. So how did we improve our protocol? In our hospital, what we have done is we created a call bell system where the moment you get a red light, this alarm is there in the anesthesia room, in the theater, in the neonatal ICU. So the moment you see a red bulb highlighting alarm, then you have to rush to the emergency section. That's a category 1A cesarean section. And so that rather than the labor room nurse contacting anesthetist, contacting neonatologist, and there's a delay. So by this response, what we have done is we could truncate the time, and our category 1A is about 7 to 10 minutes, and category 1B also is about less than 30 minutes. So we don't have to rush, especially when you have a morbidly obese patient, or when you're anticipating major obstetric hemorrhage, or when you have a problem case with a patient in heart failure. Stabilize the mother, put an IV, decongest the lungs, and then plan anesthesia. So the risk management strategies for anesthetic management is a thorough PAC, and see that you do platelet count in appropriate cases. PT-INR, especially the mother is on has a prosthetic heart valve and is on anticoagulants like UFH or any of those things. You just get an APTT done. Or we have factor 10 inhibition assay also available in our hospital, other hospital. And if necessary, reverse the anticoagulant, especially warfarin, like giving protamine, or sometimes if the mother is on unfractionated heparin, you may have to give protamine to reverse before you institute a safe spinal. Take a high-risk consent, and always do a risk assessment by WHO cardiac classification or SIU Surmer risk assessment. Counsel the patient, educate them, and again, ask yourself whether the infrastructure supports handling the patient. Otherwise, transfer the patient to a higher center. Stabilization and transfer to a higher patient. Blood and blood components to be reserved in appropriate cases, and preparedness for ABCs, ACLS, and PMCD for all cases. So that before you embark upon anesthesia, see that the drugs are, the emergency drugs and trolley are properly checked, and difficult airway kit also is available. preparation is very important. We generally, most of the cases we do on the lateral position in our hospital, and focus is used, especially in morbidly obese patient, especially when you have back like this. And as I said, the technique of choice in our hospital is programmed epidural, avoiding bicarbonate. We always use lubricant with adrenaline and fentanyl. And always remember that parturients have engorged veins. Incidence of bloody taps is very, very common. So we need to make sure that you don't end up with a bloody tap. And so the moment you identify the space, distend the space with saline, hold the plunger, allow the saline to diffuse into the epidural space, then thread the catheter to minimize inadvertent vascular bloody taps. We invented this technique, a continuous saline flush technique in our hospital. We did a RCT also. Basically, this is nothing but you identify the epidural space, and once the needle is in the epidural space, you thread the catheter with saline flush, so that you're flushing the saline continuously while you're advancing the catheter in the epidural space, so that you can minimize bloody taps. Second technique of choice is low dose CS, as I said earlier. Technique of choice, low dose CSC, low dose spinal, like 5 to 6 milligrams, and subsequently you can do volume expansion to achieve a block of D4 or D5 to D4. And continuous spinal technique also can be used, but as I said, we use only as a teaching tool, not on a regular basis. If you have to give GA, see that you adequately pre-oxygenate with HFNC or with CPAP if necessary. If the patient is obese, then put a ramp. And if it is a difficult airway, very, very difficult airway, regional is contraindicated, then awake tracheal intubation has to be planned with fiber optic or video laryngoscope, and always have a difficult airway kit and a management plan. If you have to convert a laboring patient for cesarean section, we have an algorithmic approach. I can take the questions, paucity of time, but always put a wedge under the right hip, especially for this section, so that you can maintain adequate preload. The mantra of handling a cardiac parturient is we need to maintain the 5 parameters. The preload, maintain preload by supine, minimizing supine hypotension syndrome, myocardial compression, minimize, optimize afterload, maintain adequate cardiac contractility, maintain good rhythm, stable rhythm, and see that you maintain adequate stable heart rate. Avoid extreme tachyarrhythmias or bradyarrhythmias. So if you monitor these 5 parameters, preload, afterload, contractility, rate, and rhythm, most of the patients, they go very smoothly. Other thing that you need to remember is parturients are having low oncotic pressures, and they are prone for pulmonary edema. So fluids have to be guarded, not more than 0.5 to 0.7 ml per kg per hour. Again, as I said, short NPO period, so that you can put them on orals. And extremes of blood pressures, NIBP may not be useful. So you have a low threshold to put an arterial line, and if necessary, put them on advanced hemodynamic monitoring tools. Yeah, one thing you have to remember that all these advanced like flow track, Vigilio, their algorithms are based on IPPV with tidal volume of 8 ml per kg. And if you're giving a renal anesthesia and putting these monitors, you may not get accurate values, but nevertheless, they are quite helpful. And POCUS is very, very useful in your volume assessment. You have to be very judicious with usage of oxytocin. Avoid carbetocin. We don't want to give a drug which has a prolonged action, because we know that oxytocin can cause tachyarrhythmias, can cause systemic vascular resistance is lowered, and they are prone for hypotension. So use just 3 units as a slow infusion, never as a bolus, because bolus oxytocin itself can cause cardiac arrest. Very, very careful. So we don't want boluses of oxytocin, always as an infusion. Avoid carbetocin, because half-life of oxytocin is about 7 to 14 minutes, and half-life of carbetocin is about 90 minutes to 120 minutes. So it's a long-acting. So to reverse the effect of on the hemodynamic parameters takes time, and you may end up with a morbidity. Carboprost can be avoided if the mother has severe pulmonary hypertension. Methylargometrin to be avoided. And if the mother has ectonic PPH, go for surgical methods like CHO sutures or any of those bleach and other things. So when you have or anticipating major obstetric hemorrhage, what uterotonic has to be used? See that you have a plan charted out with your obstetrician and yourself, depending on the underlying cardiac lesion. What is the effect of uterotonic agent on preload, afterload, contractility? And based on that, you can put on plan A, plan B, plan C, uterotonic agent, so that you don't have confusion whether to use carboprost, whether to use methylargometrin, whether not to use misoprostol, when to use, when not to use. Those things have to be started out. And post-op analgesia, you can give any of those, like intrathecal morphine is a drug of a technique of choice in our hospital, but tab block, rectus block, or QL block also can be given. And post-op PIB pumps, programmed intermittent epidural boluses, or any of these things can be given. The prospect guidelines are quite useful, but and you always go for multimodal analgesia. So in our hospital, we use morphine as a routine. Paracetamol is given routinely, and of course, fentanyl infusion, or if the mother has epidural catheter, indwelling catheter, make sure that you get give good analgesia. Importantly, if the mother is going to be on prophylactic, therapeutic dose of heparin, then you remove epidural catheter postoperatively and see that the therapeutic anticoagulation starts within 6 to 8 hours after surgery. It's very, very important. Postoperative care, ERAS for all patients, including cardiac patients, short NPOs, ambulate as soon as possible. Initial breastfeeding, in fact, we do the walk, put the mother baby on the breastfeed immediately on table. Remove Foley's early. Even if the patient is on diuretics, you can remove Foley's early. Use UFH initially or enoxaparin prophylaxis, and after 48 hours, we put them on oral anticoagulants if there is need. Epidural removal, especially as per the guidelines. So ERAS for all. So to conclude, I would say that Class 3, Class 4 compromised patients, refer them to a higher center if the infrastructure doesn't support. Stat cesarean sections sub-classify into category 1A, category 1B. 1A is 15 minutes you have, so spinal or early epidural or GA is the best choice. 1B, you can use whatever modality you are comfortable with. Have a multidisciplinary team, have a preoperative huddle, and obtain consensus on problem cases, anticipated problems like pulmonary embolism or postpartum hemorrhage, so that everybody is on the same page. And of course, this mother can require any of these higher cardiac interventions like ECMO, balloon pump, ECMO, peace percutaneous interventions, commissurotomies, or cardiopulmonary bypass for valve replacement. So experience centers, shifting to experience centers is mandatory if you don't have infrastructure supporting that. Early labor epidural is born for all cardiac parturients. Programmed epidural is a technique of choice. Avoid spinal in class 3, class 4 patients. That's what our protocol is. Invasive monitoring is the technique of choice for these patients. Judicious use of oxytocin. Follow standard guidelines for infective endocarditis prophylaxis, anticoagulation, and your neuroaxial blocks, and appropriate ICU care. And these parturients, especially PPCMs and patients who are in heart failure, they may require anticoagulants like LMWH for at least for 4 weeks, minimum 4 weeks, not for 5 days, not for 3 days. Parturients with ejection fraction less than 40%, they require LMWH for at least 4 weeks so that you can minimize the risk of postoperative pulmonary embolism. With this, I conclude my talk. I can take the questions. Thank you very much. Again, I thank the ICA for giving me this opportunity.
Thank you so much, Dr. Sunil. And now we will have Dr. Ravindra from Shivamoga.
Yeah.
Ravi, you can share your slides.
Yeah, good evening. Let me share my screen. Yeah. Are you seeing the screen, ma'am?
Yes.
Yeah.
Yeah. So, first of all, let me thank the ICA organizers and the entire Indian College of Anesthesiologists for having given me an opportunity to share the this stage on a wonderful time, at a wonderful time, 200th webinar. Of course, this is my second appearance on this stage. Thank you so much. So this is one other field wherein we need to be careful about. High spinal block is spinal so simple. So it has been nearly 126 years since the first spinal anesthetic has been given in 1898 and by August Baer and Augustus Hildebrand. And since that time, spinal anesthesia has seen a roller coaster journey, going to the highest level of popularity at one given point in time and to the lowest level of popularity at the other. And today, it across all the 7 continents of the world, the most popular and the commonest anesthetic that is used is a spinal anesthetic. Why is it so popular? it's a very simple technique, you see. It has a definite endpoint. You see the CSF dripping. So that's why you know where you're definitely injecting. It gives a complete anesthesia with a very small amount of drug. And it's a most reliable, one of the most reliable techniques. And this is the reason why it becomes very popular. The reasons for choosing subarachnoid block over general anesthesia for cesarean delivery most of the times, it's obvious. The first and the foremost reason is that it is a very good technique. And second thing I would say, that we choose spinal anesthesia because of laziness. Whatever the condition of the patient is, whatever the indication for cesarean section is, we tend to give a spinal anesthetic because we are lazy to do it. So those days when I was, to start with, if you give a general anesthesia, you had to stand and ventilate. Of course, we have all the facilities these days. Whether you have such facilities or not, you have to stand there and monitor. For spinal anesthesia, it's very simple, you see. You give a spinal anesthetic, the surgeon is operating, you sit there and you do your WhatsApp. Now, this is one of the reasons why spinal is chosen. And if that is the case, if you choose your spinal anesthetic for the reason you want to do WhatsApp after giving the spinal anesthesia, that is bad. The second reason is one size fit all. Cesarean sections give spinal anesthesia. Now, this is another reason. Any cesarean, you do spinal anesthesia. One size fit all attitude is bad. Just because you fit in there doesn't mean that you belong there. Just because you can give a spinal easily doesn't mean that it is the right technique. The other most important reason is its inherent safety itself. Supposing you give 100 spinals and just sit there at the corner, don't do anything. Even with 100 cases, not doing anything also, nothing happens normally. And this will make us a little, will make us complacent. We become lazy, we don't monitor. And this is the reason why many times we may land up in complications. There will be complications. And that's the reason why we should be very, very vigilant. And one such complication could be a high or a total spinal, which is a potentially fatal complication, yet mostly preventable and promptly treatable if recognized early. Now, this is the most important reason why we need to be very careful about. Now, how do we define? Definition of this condition is very difficult. We have not made a definite definition as such. The textbook description, definition is that it is a clinical block well above the levels required for the surgical anesthesia, could constitute a high block. So considering this, for a cesarean section, if T4 is the level of the block that is required, and we get a block up to T1, which we call it a high block. But in the absence of significant sequelae like respiratory compromise, bradycardia, or severe hypotension, this is an acceptable result. Many a times we tend to accept this level of high block. But a block above the cervical level, which is called a complete or a total spinal, could be dangerous. So three things have to be monitored. I would say these are the three cardinal signs we need to monitor. Number one, if the patient can flex her fifth finger, the little finger, then the C8 is intact. C8 is intact. That means that it is below the level of the cervical levels. If the patient has a good hand grip, it means that it is below C4 or C5. That again is a wonderful thing that can happen. If the patient is able to speak, it means that the block is below the cranial nerves. Now, if you can monitor these three things and be happy with it, then you are done with the monitoring for the clinically, you have done with monitoring for existence of a high or a total spinal block. Now, clinical manifestations can be divided into a cardiorespiratory and a neurological classification. Cardiorespiratory, we all know, high or a total spinal will have hypotension, bradycardia, respiratory compromise, apnea to if it becomes extremely high, reduced oxygen saturation, difficulty in speaking or coughing, and ultimately a cardiac arrest. The neurological ones are the nausea and anxiety because she is not unable to breathe or speak, arm or hand paralysis or dysarthria, high sensory level of the block, cranial nerve involvement, or loss of consciousness. Now, these are all the neurological complications. Now, respiratory distress or apnea could be there. Severe respiratory dysfunction or apnea may occur without loss of consciousness. So when the patient is having a severe respiratory dysfunction or apnea altogether, patient could still be conscious. So you need to be very careful about managing this patient. You have to appropriately reassure the patient. Patient will still be able to listen to you, talk to you. Yeah, will still be able to listen to you. So appropriately psychological reassurance has to be given. And if you want to intubate or do any airway manipulation, better use an induction agent before you induce. Now, these are some of the cardinal rules of management of high or a total spinal anesthesia. Now, coming to the incidence of the total spinal, we can almost say it is unknown because we don't have a definite statistics on what is the percentage of people who would develop a total spinal block. But the point is that there are numerous case reports, but very little limited case series. So the evidence for the incidence is not robust. A recent Danish retrospective cohort study, this is a little promising study. It reviews 636 spinal anesthetics for cesarean section and did not record a single instance of complete or total spinal block. This study included 128 cases of spinal anesthetics following the presence of a labor epidural catheter also, but still not one had a complete or a total spinal block. High spinal block, of course, they do not define it very well, but the high spinal block incidence was in and around 1%. See, the problem is 636 spinal anesthetics is not a very big number to count on the incidence of complete or total spinal block. And this is one of the drawbacks of this study. There are a few risk factors. What are the risk factors of development of complete or total spinal block? Let's see, the first classification is drug factors. The block height is more dependent on the dose than the volume. The total mass of the drug is more important. Supposing you have a 0.5% bupivacaine, 2 ml, 4 ml, or 1% bupivacaine, 2 ml, the effect, the level of the blockade will almost be the same. The volume matters less than the dosage. So mass of the drug is more important. Baricity. Hypobaric drugs spread cephalic more and higher than the hyperbaric drugs. That is why the hyperbaric drugs are more safer from the point of view of a high spinal block. A prior drug administration, like such as like an epidural which is running earlier, could have diffused, the drug could have diffused into the subarachnoid space or could have distended the epidural space, and that is why if that is there, there is a higher risk of the development of a high or a total spinal. There are some patient factors as well. A body morphology like higher BMI or abdominal girth. So from that point of view, if you see an obese parturient or a multiple pregnancy or a hydramnios, the possibility of a high spinal block is higher. In all these situations, the spinal CSF volume would have reduced And that is the reason why the spread becomes much more. Anatomical and pathological factors like compressed thecal sac, there could be epidural fluids, or the compressed thecal sac, the epidural plexus of veins, the Baston's plexus, could have engorged because they are valveless, increased intra-abdominal pressure because of the term pregnancy or any other tumor or hydomnias or whatever it is. It could increase, it increases the epidural volume. When the epidural volume increases, the subarachnoid space is narrowed, the spinal CSF volume is reduced, and that's the reason why the height of the block would go up. There could be some technical issues as well. The higher lumbar insertion, for example, if you put a spinal needle somewhere in L1-2 rather than putting it low towards L3-4 or L4-5, the drug can spread cephalic more than with a lower insertion in the supine position because of the lumbar lordosis. Body position at and following injection. Sitting position can minimize the cephalic spread. Now, if you see this, for example, we have given a spinal at say L4, L1-2 or L2-3, and you find that there is a high spinal, and if the high spinal is there immediately, it would lead on to hypotension. Now, within anxiously, if you give a head down tilt at this point in time to treat the hypotension, patient would develop a total spinal, and that could be really deleterious. For that reason, never give a head down tilt when you face with a high spinal immediately. So to treat the spinal hypotension, never give a head down tilt. There are two important determinants of a high block. Number one, the mass of the drug. Number two, the spinal CSF volume. Now, these two things have to be properly kept in mind. Now, from the management point of view, management is always supportive, dependent on the degree and height of the block. Early recognition is vital, as block progression may mitigate the block level. The reverse Trendelenburg or head raised position is more important. Typical features can be managed like this. Bradycardia, of course, vagolytics and atropine. Before all these things, a left uterine tilt becomes absolutely mandatory. Now, after doing that, use a vagolytic for bradycardia, sympathomimetics like ephedrine or adrenaline, hypotension, vasopressors, metronidazole, phenylephrine, norepinephrine, fluid boluses, leg elevation, all can be used. Respiratory dysfunction, always oxygenate first, and NIV probably becomes very handy, and NIV would probably solve the problem most of the times, but in case it becomes really essential, intubate and ventilate. Loss of consciousness, if the patient has lost consciousness, secure the airway. Supportive measures have to be taken into consideration. There are three special situations where a high spinal is expected to a very great extent, and it has to be managed thoroughly. First one is spinal plan for a failed conversion of the epidural labor analgesia into a surgical anesthesia. For example, the patient is having a labor analgesic, an epidural catheter there for labor analgesia, and for some reason cesarean section is planned. At that point in time, you charge the catheter, and the catheter epidural has failed. Now, if the epidural has failed to convert, for example, if you want to remove the catheter and give a spinal, this is one situation where a high spinal or a total spinal is a great possibility. So what happens normally is, if when you distend the epidural space, you put volume into the epidural space, it distends. When it distends, it displaces the CSF in the spinal canal above and below, and the spinal CSF volume is reduced. And this effect is known as the epidural volume extension. Epidural volume extension. Now, this will come into play, and that's the reason why after a large bolus of epidural for up to within the last 30 minutes, if you want to give a spinal, need to be very, very careful. A higher block is always expected. And if you have given it a large bolus in the last 30 minutes, reduce the spinal dosage, usually 2/3 of what is required, about up to about 9 milligrams of bupivacaine heavy in a normal height, in an average height parturient is safe. The second one is some of these case reports. You see, just concentrate on the epidural content, the local anesthetic bolus. These are fairly older studies, and if you see in the last 30 minutes there was a large bolus, and you see the incidence of high spinals. Now, whereas the relatively more recent studies wherein no bolus was given in the last 30 minutes and they have given a spinal with almost the same amount of the drug, and there was not a single total spinal at all. So what is important is to see whether you have given a large bolus dose in the last 30 minutes or not. The second situation is a repeat spinal plan for a failed spinal, that too partially acting. For example, if there is a total failure, there is no sacral analgesia after 20 minutes, repeat spinal is advocated, and the dose is the same as the previous dose because it is a total failure. Whereas if it is a partially failure or insufficient level, unilateral block or a patchy block, you want to repeat a spinal, now is the question. What is to be done? How much is too little? How much is too much? You never know. Now, what is the possibility of high or a total spinal? Now, if the block is lumbar, that means that the level of the block is not higher. That means that if the sensory level of the block is well below the symphysis pubis, in that case, 60 to 70% of the original dose can be given. Up to 9 milligrams of bupivacaine heavy is fairly safer. The last situation is an extremely short-statured individual. You have to be very careful in titrating your dosage in an extremely short-statured individual. I would always prefer you to place an epidural catheter and give a very small dose, say about 5 milligrams, 4 milligrams, an extremely short-statured individual, spinal. And then if the level becomes less, then you would probably, if the level becomes less, use the epidural catheter for supplementation. And that would probably the answer for avoiding a high spinal. So the take-home message is that the total or high spinal is a definite entity, though rare. Be vigilant. Risk is high in these three situations. Situation number 1, spinal block after an epidural top-up in the past 30 minutes. Repeat spinal after a partially acting spinal. Short-statured parturients. Manage them carefully. Thank you. Thank you, ma'am.
Thank you so much, Dr. Ravi.
Thank you, ma'am.
Such an interesting lecture. And now I invite Dr. Anju Grewal for a
Thank you so much, ma'am.
Yes, that is the last lecture of our series.
A very good evening to all, and at the outset, a big thank you to Dr. Sunanda ma'am and to ICA for giving me this opportunity. I know you all are exhausted and of course hungry as well. So I will try to limit my talk as much as possible. Wait a minute. Share my screen.
Go back to Zoom and then you can share the screen.
Is screen visible
No. Yes.
now?
Yes.
So a very good evening to all. I thank the ICA and Dr. Sunanda ma'am for giving me this opportunity. I'll be talking to you about maternal cardiac arrest. I know the topic is perioperative cardiac arrest, knowing the algorithm by heart. So I thought the best scenario is always a preoperative scenario where we still have the baby on board, and that is where most of us will be, in a fix and probably would need more vigilance and attention to maternal CPR. So the scenario that I would be discussing is a full-term parturient scheduled for an elective cesarean section. It's a nice category 4 for the next day. And, they gave an antibiotic test dose. She develops rashes, difficulty in breathing, and another few minutes. She's unresponsive and gasping. Remember, she's in an antenatal ward, which is a block away on the same floor as the labor OTs are situated. So a little away from the labor OTs that you are. And to overcome this issue, I would recommend all our viewers to go through this guideline. This is a consensus statement by the Association of Obstetric Anesthesiologists India, which I would be referring to for this talk. So what are the challenges that we are looking at in a parturient who is full-term pregnant and still has a baby on board is that as we have all discussed in the entire evening, is we have an aortocable compression that is decreasing the cardiac output by up to as much as 50%, an increased demand, or more often than not, they're anemic, they have a decreased FRC, poor oxygen reserves, they desaturate fast. And of course, they have difficult airways, increased risk of aspiration. Evening prior, she would be well fed because she has a surgery tomorrow. So all of these would make our CPR ineffective or challenging, I would say. And a priority is therefore for these challenges is not only to institute high quality CPR, but is also to relieve the aortocable compression. So it would be either by maneuvers or by early evacuation of uterus. And of course, to have an early definitive airway and oxygenation on board as soon as possible. So what do you need on these is a minimum of 4-member team, which would at the outset ensure that they have, recognize that there is an arrest and calls for help. And indeed starts with high quality chest compressions as the help is coming along. It's a second member who has heard your cry and has come to your help would notify the maternal code blue team, note the time, and then help you with an AED and get another one to perform manual left uterine displacements. And then, of course, as you are joined by others, we can go on to other interventions. So if you look at it in an algorithmic way, so what we're actually looking at is a parturient who has collapsed in the ward. And as is always true for all CPR guidelines, when we talk about scene safety, it's first for the provider and then the parturient. And we always check responsiveness, something that would be missing if you would have a cardiac arrest on the operating room if your patient were under general anesthesia. However, if she is under spinal, and we had just had a talk of high spinal, she could be talking to you, getting restless, and then suddenly stop speaking to you. That is a point in time where responsiveness needs to be checked for this mother. And then if you do not get any response, you indeed, the first and the foremost step is to call for help and note the time and call for a maternal code blue team. Now, what is a maternal code blue team? Is a team of providers which comprise of not only anesthesiologists, but also obstetricians and neonatologists. And so that we can initiate as early as possible, which is known as perimortem cesarean delivery. So we need to get the team onto the site of cardiac arrest. But if you're in the operating room, you have the privilege of all of them being there at all the times with you. And of course, we need to get a crash cart, a defibrillator, and I said we need to note the time because we need to initiate our perimortem uterine interventions as soon as possible. The next on board would be to assess breathing and carotid pulse. Now, for the students, I would say this is a very, very important point because even when you are there in the operating rooms, more often than not, do not try to wait for an asystole to occur. These mothers would get into cardiac arrest in a PEA algorithm, meaning thereby that you would get a organized rhythm on the monitor. However, if you palpate the carotid pulse, it would be absent. right? So that's very important to palpate the carotid pulse. And then if it is absent, start with high quality chest compressions, combining it with manual left uterine displacement, something I'll talk to you a little later. And then we all are familiar with the 30:2 chest compressions. We do 5 cycles of which, and as soon as a team is ready to do the PMCD or the uterine interventions, we go ahead and combine these resuscitation with resuscitative uterine interventions. Now, resuscitative uterine interventions is a term that has been introduced by AOA in place of PMCD. So the first and foremost is instituting high quality CPR. We need to follow the CAB algorithm. You're all aware of the elements of high quality chest compression. What we need to remember, there is no change in the hand location. And by all means, we should monitor the quality of chest compressions. If you are in the intraoperative setting and you have access to an ETCO2, or you have, you can utilize that by at least shoving in on a second generation or an endotracheal tube in a mother whose airway has not been secured, or if the mother's airway is secured, attach the ETCO2, which will help you to monitor the quality of chest compressions to aim an end-tidal carbon dioxide level of more than 10 millimeters of mercury. Okay. And of course, we need to combine excellent team dynamics here, because the more interruptions in the chest compressions, the less likelihood that the mother is getting to good outcomes. So that's very important to measure your chest compression fractions. One of the most important interventions that are essential to maternal CPR is maternal left uterine displacement. You need to institute that, and especially in whenever the fundal height is at or above the level of umbilicus, this is the most beneficial intervention. So you need to assign a provider who continuously performs manual left uterine displacement and does nothing else. The best way is to be on the right side of the mother and on the left side of the mother, to pick the uterus from the right side and then take it to the left, or you can even push it from the right side to the left. So these are the ways with which we can institute manual left uterine displacement, something that should not be forgotten and should continue in tandem with the CPR, right? What is not recommended is putting a wedge at the time of chest compressions or tilting the table, because that would result in less force of chest compressions coming in. Okay. Another very important vital part is to have an early advanced airway management. And therefore, if you are on the floor and you're part of the airway maternal code blue team, you need to anticipate that the first attempt should be your best attempt. So if you have access to a second generation supraglottic device, that is the best thing, because you need not stop the chest compressions to put it in, and therefore can go ahead with even an ETCO2 on graph and monitor the chest compressions as well as continue with the CPR. You should use intubation is only to be attempted in an optimized manner. And when we talk about optimized manner, is using the best devices, especially a video laryngoscope with which you are familiar with, in a smaller size ETG. And remember that time is clicking on you, and therefore you need to put your tube rightly in place within 10 seconds. So therefore, it's a very important decision to go ahead with this kind of device. And I would advocate that all labor floors should have a second generation supraglottic device on their crash carts. Other modifications are a reluctance to give shock, but remember that if there is a shockable rhythm in the form of a ventricular tachycardia or a ventricular fibrillation, then usual doses of defibrillation are important. You may or may not remove fetal monitors, but they should not be delaying the shock. And in labor floors where staff have poor rhythm recognition skills, it is advisable to have AEDs there. Have your IV on your has a wide bore IV. And what I recommend is that all mothers on the labor floor should have a wide bore IV and an intraosseous access if IV is not available. The doses of drugs are the same for these mothers. What is very, very important, that as soon as you start with your chest compressions, you need to think, you put your thinking caps on and think about, why is my mother in cardiac arrest at this point in time? And therefore we can go down with that newer ABCD UPS algorithm being given to us by the AOA, which talks right from anaphylaxis, and that is what our case scenario is all about today, or it could be a high spinal, an anesthetic cause, bleeding, trauma, cardiovascular. So all of these should be there in your mind. And the best way to get them is to have a very focused history using a acronym sample from the mother, which talks about symptoms, signs, allergies, last meal taken, what were the events, and other kind of focused history that can lead you on to all these kinds of underlying causes of maternal cardiac arrest, and you must be able to recognize to treat them well properly. One of the most important intervention is, despite the manual left uterine displacement, there is still a significant amount of the blood flow that is being compromised, and therefore evacuating the uterus is extremely important if the pregnancy is beyond 20 weeks. So it's very important to institute perimortem cesarean delivery, the term that was being given. However, this term came with a lot of morbidity, and therefore in AOA, we thought we should change it to resuscitative uterine interventions. Remember, this comes with a big cognitive load, and this has to be performed at the site of cardiac arrest, and not the patient should never be moved to the labor OT if the patient is still in the ward. So wherever the patient is, stick to the 5-minute rule from the time of arrest. If there is no return or spontaneous circulation at 4 minutes, by 5 minutes, we should be able to deliver the baby. And this needs a lot of teamwork, a lot of preparation, a lot of readiness on the part of your maternal cord blue team, especially your obstetricians, who needs to be supported to go ahead and do it at all times, right? And then remember, even if you have done a perimortem cesarean delivery or a resuscitative uterine interventions, PPH is very much on board, and hence we need to be cautious on the use of oxytocin. So the drug on board would be methylergometrin or prostaglandins. We must have lower threshold for uterine compression sutures, and if there is a lot of bleeding, internal iliac or aortic cross clamps can be used. Post resuscitation, it's important that we shift these mothers to an ICU and institute measures to improve the neurological outcome if she's not still conscious enough. So it's very important to remember that there are other very important considerations as we resuscitate these mothers. And those are, as you all are aware, is teamwork and situational awareness. Know where you are on the perioperative horizon. Are you in the preoperative? Are you in the intraoperative or the postoperative period? Do a real-time documentation. Do assign a provider to do who becomes a recorder and does a real-time documentation, gives you timely feedbacks. Be aware of the ethical issues. Do a debriefing after the event is over, and always do an audit so that we keep learning from these and continue to upscale yourself by training and mock drills at whatever opportunities that you get on. And remember, since this is a situation of high cognitive load, it is good to have cognitive aids attached to your crash cart. So this is one cognitive aid that comes from the AOA, which you can easily hang on to your crash carts in the labor floors, which will tell you how to go about doing combining basic life support and advanced cardiac life support for the benefit of our mothers. And then most importantly is to combine resuscitative uterine interventions. And therefore, your mock drills should always involve your obstetricians whenever you perform them on labor floors. So in the end, my take-home points are: most important is to prevent and detect cardiac arrest early. Be vigilant at all times. Document the time of cardiac arrest and do activate help in the form of maternal cord blue team. Assign specific roles to a minimum of 4 responders, of which 1 role should be for instituting manual left uterine displacement at all times. Initiate high quality CPR, that is chest compressions and defibrillation if needed, and secure an early definitive airway, trying to give as much as oxygenation, 100% oxygenation as possible. A second generation left supraglottic device is extremely handy in these situations because they are difficult airways, and therefore these can be put in easily by even providers who have less proficiency with airway management skills. Remember your causes, think about them, and keep treating them as you do your CPR, and then promptly at the 4th minute, initiate resuscitative uterine interventions to deliver the baby by the 5th minute and hand them over to the neonatologist for resuscitation. These mothers do need post-resuscitation care as their non-pregnant counterparts. And as I said, we need seamless teamwork, training, and incident audits to improve and make and safeguard the health of all our mothers. Thank you all for a very patient hearing. Thank you so much. I love to have questions.
Thank you, Anju. And so now a quick take on all the questions which have appeared in the chat box. First question is to Dr. Sunil. Can or should we preload the cardiac patients? Sunil.
The concept of preloading is no longer for almost about a decade, a couple of decades back, we stopped preloading the patient, which was conventionally taught to us during our PG days, that before you give regional anesthesia, we need to preload the patient with a crystalloid, and then came colloid, and then combination of crystalloid and colloid. All those have become just archaic. So what we follow currently is co-load, but cardiac patient, we don't even co-load. We just have to be cautious with the fluid administration, because especially compromised patients, NIHA class 3 and class 4 patients, just have a wide bore venous access, have a heart line. And once you institute a regional anesthesia, either a programmed epidural or a low dose spinal with epidural volume expansion, or even sometimes a single shot spinal, what we do is we do not allow hypotension to occur. We prophylactically prevent hypotension, proactively anticipate and give prophylactic vasopressor, either a low dose noradrenaline infusion or a phenylephrine infusion, so that we maintain minimum maps. We don't allow blood pressure to follow. So the concept of preload with fluid is should not be followed. So take the help of prophylactic vasopressors early and proactively.
Thank you, Sunil. A question for Dr. Ravi. What are the factors or maneuvers which lead to a total spinal? Ravi? Ravi,
You have
please
to
unmute.
unmute. You need to unmute.
Yes.
What was the question, madam? What are they?
What are the factors or maneuvers which lead to a total spinal?
Yeah. See, the first and the foremost is the dose of the drug. We need to be very, very cautious with our dosage. That's number one. The second one is head down tilt. Whenever we have to treat a hypotension, should always be avoided. The another important thing I mentioned earlier itself is that if we have given a large bolus of epidural in the last 30 minutes, we need to reduce the dosage of the spinal subsequently. Now, these are all the maneuvers I think we need to be careful about.
So along with this, another question which comes is, if we give a head down position after a hyperbaric spinal, will there be a cephalad spread?
Yeah, see, the question is that if there is a if the level of the block is low, that means that the drug has settled in the sacral trough. That time, if we give a head down tilt, it will not ascend at all. Whereas if there is already a high spinal block, that means that the drug is mostly in the thoracic segments. If you give a high head down tilt, it will ascend.
So normally the practice of giving a head down tilt once the spinal is given, what would you say? Because at that time there is no fixation there.
No,
Immediately after a spinal in a pregnant woman, when they make
supposing we have given a spinal in a higher space, say around L1, 2 or L2, 3. And at that time, if you give a head down tilt, it will ascend higher. Whereas if the spinal is given at a lower space, L3, 4 or L4, 5, then the drug becoming, the level becoming very high does not happen. Now, I think Dr. Sunil can answer this question better because he has a spine model. If the drug has already ascended and if there is a high spinal, at that time, if you give a head down tilt, it will ascend further. Sunil, please.
The thing is, like, see, one of the things that we have observed in our large clinical practices, the head down tilt does not result in exaggerated spread because of the natural thoracic kyphosis at D4 level, where the hyperbaric drug goes ascends up to the D4 and stops. Only it doesn't go because you need to go against the convex area of the dorsal spine. But yes, if the drug already has gone beyond the kyphosis, like thoracic kyphosis, it's already
Yes,
a D2, then you give head-on tilt, definitely you end up with a high spinal. So the mass of the drug and the dose of the drug which you have injected, the volume and the mass are the major determinants of high spinal. Yes.
And,
that's what.
yes, another question which comes up is if the patient already has nausea and vomiting, which precedes hypotension, so should we give an antiemetic and ephedrine at this time without the patient showing any hypotension? Yes, Ravi, would you like to answer that?
Yeah. Ma'am, a vasopressor should be the first choice. And then we give an antiemetic.
Correct.
Yes. A vasopressor should be the first. We have to prevent a precipitous hypotension. We may not have recorded. See, most of the times what we do is the non-invasive blood pressure monitoring. We may not have recorded the hypotension properly. So the best thing to do is left uterine displacement, a vasopressor, and then an antiemetic. Have I answered your question, ma'am?
Yes, I think we all agree to that.
Absolutely.
Yeah, thank you, ma'am.
And I think with this, all the questions in the chat box are over. And I thank all my team of speakers on the symposium. And I hand over the proceedings to the ICA executives. Madam Jayashree Sood.
Thank you very much. Thank you all.
Thank you.
Thank you. Thanks, Sunanda. Baljit, are you there? Maybe he's not. Okay. So I have been given the privilege of proposing the vote of thanks. Actually, Baljit was supposed to do. And it's my pleasure to thank you all. It has been such a, a tremendous webinar. I can't explain and I can't praise. I don't have words to praise that because all the stalwarts were here and all the case scenarios that were taken are so relevant, and we do see these in our daily practice. And thank you so much for that expert advice and expert comments. And thanks a lot, Sunanda, for the moderation. Thank you, Akila, Dr. Ravindra, Dr. Kajal, Dr. Sunil, and Dr. Anju. It has been such a pleasure. And thank you so much. And really, you made this 200th mark absolutely memorable. Thank you so much. Thanks, Shweta from Clanet. So we hope to see you very soon. As Sunil says, this is the second one he's attending. He's participating, but surely we are going to make sure that you all please contribute a little more. Thank you very much. Thank you. Good night, everybody.
Good night.
Thanks,
Thank you, ma'am.
Anish.
Good night. Night. Thank you all.
Good night.
Thank you, Dr.
Good night, Dr.
Radhakrishnan.
Radhakrishnan.
Yeah,
Thank you
thank
so
you.
much.
Thank you. Thank you all.
Thank you. Thank
so
you.
much. Thank you, everybody.
Thank you.
So with that, we come to the conclusion, everyone. Thank you so much for letting us host the session today. I hope you all had a seamless and hassle-free experience. So with all your last comment, we are concluding the session over here and really looking forward to hosting you all again. Thank you so much and good night to all of you.
Thank you,
Thank
Shweta.
you. Good night.
Thanks, Leonard.
Thank you. Baljit, you were there.
Yes, I was there.
Oh, anyway.
Some time to my video.
So sorry.
So nice to see you, Dr. Baljit.
Perfectly okay. Perfectly okay.
Thank you. ma'am.
Lovely.
So nice of you, sir.
Bye. Good night. Good night, Dr.
Bye-bye.
Good
Good
night.
night.
Good night. Good
You
night.
can have passing word, Baljit.
Excellent talks. Excellent talks. Enjoyed every moment.
Thank you.
Thank you, sir. Thank you,
Wonderful.
sir.
That's the spirit. Yeah. Thank you all once again.
Thank you, sir.
Thank you so much, sir. Thank you.
Good night.
Good night, ma'am. Good night, sir.